Hi, everyone. It is a great pleasure for me to be speaking to you today. I'd like to thank the organizing committee for the invitation, and I also would like to thank Dr. Maria Cristina Chamas, the president of WFUMB. So I am Paulo Savoia. I'll be talking to you about FAST protocol, which is the focused assessment with sonography for trauma. And first of all, just to give you some perspective, I'm speaking from the biggest academic health system in South America. These are the numbers of this academic health system. And we are a reference for trauma. We are a trauma center. We have around 250,000 emergency and urgent cares per year, 80 operating rooms, and more than 50,000 surgeries per year. I'm also speaking from São Paulo, which is the 5th biggest city in the world. We have around 20 million people in the metropolitan area, an area of 8,000 square kilometers, and we have 9 million vehicles here, of which 1.5 million are motorcycles. And I don't know how it is there in Taiwan, but here in São Paulo, in Brazil, it is very common for motorcycles to run between the car lanes, something just like this. So you can imagine that with all these numbers, we have a lot of trauma here. So that is the context of the FAST examination here. We know that trauma is the leading cause of death before 45 years old. We know that 80% of blunt, 80% are blunt traumas, of which 12% has intraperitoneal bleeding. The majority of death is due to hypovolemic shock. And the FAST protocol has one main objective, which is to identify the bleeding as soon as possible. We have now more than 3 to 4 decades of experience and evolution of the FAST protocol throughout the world. And it replaced diagnostic peritoneal lavage, the DPL, and reduced laparotomies substantially. So basically what you have to do in the FAST protocol is to identify the free fluid, which basically is blood in the context of trauma. So we have the traditional FAST, which will look for free fluid in pericardium and the peritoneal cavity. And we have the extended FAST, known as eFAST, that will look for free fluid in pleural spaces, which would be hemothorax, and also to search for pneumothorax. And you may also look for additional findings. These are not on the traditional FAST nor in eFAST, but you can also look for solid organ injuries in some specific cases, and also for fractures. This might be useful when CT is not available and or we have stable patients. I'll talk you through a little better about this afterwards. So let's continue here. So who will be the patients that you will perform the FAST protocol? So we have 3 classical indications for the FAST protocol. Blunt abdominal trauma in hemodynamically unstable patients, patients that have penetrating trauma of the thoraco-abdominal transition in which there is doubt of penetration into the abdominal cavity, unstable as well, and hemodynamically unstable patients with unknown cause. And you have others indications such as high energy trauma, even when the patient is hemodynamically stable. So these are the patients who we will perform the FAST protocol. And also, how is the FAST algorithm for decision making in these patients? So when you have a trauma, more important than if your FAST is positive or negative is if your patient is unstable or stable. So let's go through this a little bit. So if you have a trauma and your patient is stable and you perform a FAST and it is a negative FAST, you don't have free fluid in pericardial space, you don't have free fluid in pleural spaces, you don't have free fluid in the abdomen, in the peritoneal cavity. So this is a good scenario. You can stop, you can repeat FAST, you can send your patient to CT if there is some doubt, or you can just observe. If you have a trauma and your patient is stable and you have a positive FAST protocol, you can send a patient to CT. Your patient is stable, you can send him or her to CT to better evaluate why the FAST is positive. You can get more information from the CT. The patient is stable, so you don't have to hurry a lot. If you have a trauma and the patient is unstable and the FAST is positive, this patient's needs must go to the operating room as soon as possible. So this is the classic decision-making for FAST. The unstable patient with a positive FAST protocol, this patient should go to the operating room as soon as possible. And if you have, this I think is the worst scenario, if you have an unstable patient with a negative FAST protocol, so your patient is unstable and you don't know why. You didn't find free fluid in pericardial spaces, nor in the peritoneal cavity, nor in pleural spaces. So some authors suggest that this patient should go to CT, but it is unstable. This could be a critical condition. So if CT is kind of easy to perform, should be a good solution. Otherwise, it is a difficult scenario. Maybe you have to try to look for other causes of instability, such as neurological disorders, for example. This is the worst scenario of the algorithm. Okay, so when you will perform, you know who, and now when. So if you look to the advanced trauma life support, when you have the standardized attending system based on 5 steps: airway, breathing, circulation, disability, and exposure, you should do your FAST protocol in the letter C of the ATLS. When you access the circulation of your patient, you will look for shock syndromes and tamponates. So this is when you have to look for hemopericardium, which would be translated as a pericardial tamponade in your ultrasound. You look for peritoneal bleeding, hemoperitoneal, free fluid in the peritoneal cavity, and you look for hemothorax and pneumothorax. And where and how? So usually we perform FAST protocol in the emergency room. You don't want an unstable patient to be going around the hospital. So it is interesting that you go to the emergency room to perform the FAST protocol. If you have a portable small ultrasound device, this should be nice for you to go to the emergency room. Usually the patient has a lot of devices, so a small portable ultrasound is good for you to go through the devices and access your patient in a good way. Usually you will use a curved low frequency probe, which is the most common probe you have in ultrasound devices. And just some practical tips. Remember to have precaution for physiological fluids. So don't forget your gloves. Don't forget to protect your equipment with plastic film. So use gel on your probe and then a plastic film on the top of the gel and then gel on the patient. So you don't get to blood directly to your equipment. Leave it charged. Remember to leave it charged if it is a portable device. Don't forget the glove, don't forget the gel. So how you will perform the FAST exam? So basically we have 5 regions to access. We have the pericardial space, the right upper quadrant, the left upper quadrant, the pelvis, and the pleural spaces. Usually we go on this order. The pericardial space is the most important. Then you go to the abdomen, which might be misdiagnosed, and then you go to the pleural spaces at last. So let's see some examples, some images. In the first space, which is the pericardial space, you can access via subxiphoid access or anterior intercostal access. This is an example of a subxiphoid access when you have a normal pericardial window and negative FAST protocol. You don't see hemopericardium, you don't see free fluid in the pericardial space. This is an example of a physiological fluid in the pericardial space, which is that fluid up to 5 millimeters. This should be physiological fluid, and it is a negative FAST. It's not due to trauma. It is a physiological fluid in the pericardial space. And this is an example of a positive fast when you have a huge amount of fluid in the pericardial space. Cardiac tamponade. Remember that cardiac tamponade is a cause of cardiac arrest in asystole or pulseless electrical activity. This is another example of a positive fast in the pericardial space. You can see a lot of fluid in the pericardial space and cardiac tamponade. Then you will go to the right upper quadrant, which is the first abdominal region to be examined, because small amounts of blood, small amounts of free fluid usually may accumulate here. And when you have this region positive, you have the abdominal positive for the FAST protocol. And you have to access basically the hepatorenal recess, which is known by the Morrison pouch, which is this region between the right lobe of the liver and the right kidney. This is a normal example when you don't have free fluid in the Morrison pouch. So a negative fast. This is an example of a positive fast when you have free fluid here between the right lobe of the liver and the right kidney. And this is another example of a positive fast, very discrete. You have only a small amount of fluid, a small amount of blood between the liver and the right kidney, which would be an example of a positive fast here. Another examples of positive fast in the right upper quadrant. Here you can see a lot of free fluid between the liver and the right kidney. This you can see that the Morrison pouch has only a small amount, a thin layer of liquid free fluid, but you have a lot of fluid around the liver, same as here, a lot of fluid around the liver. So these are examples of positive FAST protocols. Then you go to the left upper quadrant, you search the perisplenic area. This is an example of a normal negative FAST. You don't have free fluid between the spleen and the left kidney. These are examples of positive fasts when you have here a small amount of blood, a small amount of liquid, a small amount of fluid between the spleen and the left kidney. Same here, a small amount of blood here, which are examples of positive fasts. Another examples of just small amounts of free fluid, small amounts of blood between here around the spleen here and around the spleen here. You have also small amount of hemothorax here. These are examples of positive fasts in the left upper quadrant. Then you go to the pelvis via suprapubic veil. Ideally, it should be performed before bladder catheterization. You remember in the letter C of ATLS, there is a bladder catheterization. So it's interesting for you to perform your FAST protocol before that bladder catheterization, so you can use the full bladder as a window to access the whole pelvis, and then you can see better this region. This is an example of a normal negative fast. You have the bladder full here and you don't have free fluid around on the pelvis. This is an example of a positive fast. You have the small bladder here and a lot of free fluid, and these are the small bowel loops here, a lot of free fluid, a positive fast. And this you have to be careful, because this is an example of a woman at reproductive age. Women at reproductive age may have a small amount of free fluid in Douglas pouch behind the uterus, and this small amount is normal, is physiological, and it should be considered a negative FAST protocol. These are examples of large amounts of fluid in the pelvis. So you have here a positive FAST, a lot of fluid in the small bowel loops here. This same as here, you can see well the bowel loops and a lot of free fluid between the bowel loops in the pelvis. And then, so now we perform the traditional fast, and you may also perform the extended fast when you go to the chest to look first for hemothorax. So you basically look for fluid in the pleural spaces. This is an example of a normal pleural space. You can see here the lung coming around and the spleen here. So you can see the pleural line and the A lines would translate a normal lung here. When you have hemothorax, you will see pleural effusion. You see liquid in the pleural space here, small to moderate amount, and here a large amount of hemothorax. You can also look for Pneumothorax. Pneumothorax, you have other presentations, I believe, this morning talking about the pneumothorax, how to diagnostic it. But basically, when you have pneumothorax, the gas in pleural space doesn't allow you to see the lung sliding. So it will look like your lung is not sliding. It will look like your lung is stopped, but actually it is not stopped. It is sliding, but the gas in pleural space doesn't allow you to see the lung sliding. So if you manage to position your transducer just in the point that ends the lung and starts the pneumothorax, you will see something like this. When you see a lung sliding at this half of the image, in this half, the intercostal space, and in this half, you can see that the lung is not sliding. The lung seems stopped, seems not sliding. Actually, it is sliding, but you cannot see because the gas here in pleural space doesn't allow you to see the lung sliding here. So you have a positive E-fast, extended fast for pneumothorax. And you have also the false positives, which you may know, which are conditions, other conditions that have free fluid in the peritoneal cavity or in the pericardial space, but are not due to trauma. For example, pericarditis, ascites, peritoneal dialysate, ventriculoperitoneal shunt outflow, ovarian hyperstimulation, ovarian cyst rupture, massive intravascular volume resuscitation. This is important. Patients traumatized may receive a lot of volume, so this may provoke intravascular to intraperitoneal fluid transudation. And patient will have liquid, will have fluid in the peritoneal cavity, but will not be due to bleeding, will be to this transudation. So an alternative would be go back to the diagnostic peritoneal lavage, for example, but these are difficult situations to deal with. And we have also false negatives when there is no free fluid in the traumatized patient and or you cannot see free fluid. For example, isolated extraperitoneal injuries. I'll show you one case. Next slide. You know, when you have superficial soft tissue emphysema, so it is normal when you have a lot of gas and trauma, you will try to perform ultrasound, you have gas in the wall, the abdominal wall, and then you will see nothing basically, because the gas in the soft tissue of the wall will not allow you to see anything beyond it. So you could be a false negative. Obese patients, when you may not see it well, or when you have minor abdominal injuries with just small amounts or no amounts of free fluid, this should also be false negatives. This is an example of a patient victim of a gunshot wound. So you have the gunshot projectile here in the anterior abdominal wall. You have the entrance here in the back and the exit here in the front. So you can see, studying the pathway, that there is a fracture of the right transverse process of this vertebra. You have an hematoma of this psoas muscle here, the right psoas muscle, if you compare it to the left one. You can also see there is lacerations of the right column and also a densification of the start of the third portion of the duodenum. So you can see that only extraperitoneal structures were hit. So this patient had a negative fast protocol. There was not free fluid in the abdominal cavity. It was repeated a lot of times, this fast, and always negative, because all the lesions were in extraperitoneal structures. So it was a false negative. And should we look for organ lesions? So most of the cases, no, you should not, because solid organ injuries are often underdiagnosed or not diagnosed on ultrasound, especially if there is no free fluid. So authors say sensitivity about 40%. And if you have an unstable patient with a positive fast protocol, this patient should go to the operating room as soon as possible. And if you have a stable patient with a positive fast, you can send this patient to CT to better study this patient. In some cases, maybe yes. If you have, for example, a stable patient with a positive fast and CT not available, you can try to look for solid organ lesions despite of this kind of low sensitivity. And for example, pregnant patients, stable, you can prevent radiation that this patient. Maybe you should do an ultrasound to try to better understand the solid organ lesions. This is an example of a patient that we could see a solid organ lesion here. You could see the laceration of the spleen, a lot of free fluid around the spleen, and some part of the fluid more hyperechoic than the other, showing that this should be a more acute bleeding than this one. So that's it. Thank you very much for your attention, and until next time.